Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Vivek Saini, gastroenterologist at TMU Hospital, Moradabad, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective, evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussions.
Hello, I am Dr. Vivek Saini. I am consultant gastroenterologist in TMU Hospital, Moradabad. And today we are having a podcast on IBS.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So, IBS stands for irritable bowel syndrome, and as the name suggests, it is irritable gut or hypersensitive gut. This hypersensitivity can be due to certain triggers, and the patient usually complains of pain abdomen, which is the predominant symptom. And apart from that, the patient is also having some bowel upsets. So it can be constipation, it can be diarrhea, or it can be a combination of both. Patient can be having alternating constipation and diarrhea.
What are the biggest myths or misconceptions you hear from patients about IBS?
So the biggest misconception which I hear from my patient is that they think that they are carrying some dormant malignancy or cancer, some serious chronic illness. Secondly, they also misinterpret IBS as IBD. Thirdly, they are suffering from pain abdomen from a very long time, and they are carrying investigations for last 3 to 4 years. So they think that the doctor might be missing something. Fourthly, they think IBS is due to some worm infection or due to some infection or due to some probiotics or antibiotic use, or they also think that it could be leading to some chronic illness that can be fatal in some time.
What simple screening questions can a consulting physician ask to suspect IBS?
I guess the Rome 4 criteria is good enough to diagnose and label the person as IBS, which comprises of pain abdomen, that is the recurrent pain abdomen at least 1 day per week for at least 3 months. Apart from that, the patient should be having pain along with defecation, and there should be change in the consistency and also change in the form of stool. So these simple questionnaires that are included in the Rome 4 criteria are sufficient enough to diagnose the patient of IBS.
What are some common mistakes in diagnosing IBS at the primary care level?
As a physician or as a gastroenterologist, one must not miss the red flag signs. The red flag signs can be anemia, blood in stools, weight loss, low-grade fever. So these can be the red flag signs that the patient can miss, that the doctor can miss. Secondly, not complying to the Rome 4 criteria is a big mistake that a physician usually do. So a patient coming with complaints of only 2 to 3 weeks and labeling straight away as IBS, I guess it's not a good practice. So these two common things we should avoid.
How do you differentiate IBS from lactose intolerance, celiac disease, or functional dyspepsia?
So lactose intolerance is primarily due to milk and milk-related products, and patient will be having bloating and dyspeptic symptoms. Pain abdomen might not be the predominant feature in lactose intolerance. The problem mainly arises after milk or milk-related products. Patient will be having some diarrhea or some bloating in lactose intolerance. Celiac disease is a serious illness. It's an organic illness. Patient will be having features of malabsorption. There will be weight loss. There will be anemia. Patient might be short stature. There can also be associated autoimmune diseases. Patient might be having type 1 diabetes. So celiac disease is altogether a different syndrome and should not be missed. It can easily be ruled out by doing a simple biochemistry test, that is doing IgA-TTG. And fourthly, functional dyspepsia. Patient will be having more of bloating symptoms or pain abdomen that is associated with eating. Bowel upsets are not very common with functional dyspepsia. So these are few small pointers that can differentiate between the four.
How often do you see IBS overlapping with anxiety or depression, and how do you address it?
It's a very common combination. Almost half of the patient having IBS are suffering from one or the other psychiatric illness. It can be either anxiety or can be depression. The main cause is because they are suffering from the illness for a very long time. Almost 3 to 4 years have already been passed, and they are doing doctor shopping here and there, and still that disease is either not explained or not getting relieved. So depression and anxiety is very common among these patients, and the main thing that we can target to relieve this anxiety and depression is showing empathy towards the patient, and secondly is reassurance that this disease is not life-threatening, nothing will happen. Patients are suffering, we should not deny the fact, but reassurance is something which works. However, if anxiety and depression is very serious, we can also start some antidepressants, or to reduce the anxiety, we can give low dose of beta blockers.
Once IBS is diagnosed, what is your first-line approach to management?
So first is to diagnose properly. We should not miss the red flags. We should diagnose as per the Rome 4 criteria. Second is definitely the reassurance, which is very important, as I've already answered in my previous question. So reassurance is the second thing. Third thing, to classify the subtype, whether it is IBS-C, IBS-D, or it's the IBS mixed type. Then the lifestyle and dietary modification is also very important, because there are certain dietary triggers that that increases the symptoms. So dietary lifestyle modification, which includes yoga and breathing exercise, stress reduction, a change in a bit of a dietary pattern. We can also go for lactose avoidance initially, just to rule out any lactose intolerance, but that is not a very strict part of dietary modification. And then we should target the main symptoms, that is a pain, for which a low dose antispasmodic is sufficient enough. Thirdly, based on whether the subtype is constipation or diarrhea. For constipation, we can give any isabgol husk, or we can also give osmotic laxative. And for constipation or for diarrhea, we can give a low dose of loperamide.
What's your opinion on the role of rifaximin in IBS-D? Where does it fit best?
So IBS-D, rifaximin is usually not the first line therapy in IBS-D. Usually when the loperamide is not working, or we are suspecting some form of superadded SIBO, then we can go for rifaximin. And in those patients, rifaximin works very well. So IBS-D patient, as a second line therapy, rifaximin is a very good drug.
What are some practical ways physicians can build patient trust in IBS treatment?
So one is definitely the showing some empathy, because patients are suffering. It's not that they are bluffing or they are having some functional issues. So they are having pain, they are having constipation and diarrhea. It's just that we are not getting anything on the reports. So all the investigations are coming down normal. So we have to show some empathy, and we have to reassure the patient. That is the most important thing. We have to talk to them. Communication is the main key. We have to reassure that nothing bad is going to happen. It's not a life-threatening illness. So reassurance is one. And treating the primary symptoms. Say for example, if the pain is predominant, we should treat the pain first. If constipation is the main thing, then we should focus on the constipation. Apart from that, we should also focus on the lifestyle and dietary parameters of the patient. So it's a holistic approach towards the treatment of IBS, and not just prescribing medicines.
What's your message to young doctors who hesitate to label a case as IBS?
So for the young clinician, judicially use the investigations. Don't over investigate the patient. Follow the Rome 4 criteria. Once the patient is being labeled as IBS, then reassurance and good communication skills plays the main role. Don't overuse antibiotics, probiotics, neuropsychiatric drugs, because they can also have some side effects. So all these things should be taken care by the young clinicians while treating the IBS. I would also like to thank the team for holding this podcast, and it's a very informative one.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.